My name is Iqbal Malik. I'm a cardiologist, and today we're going to be talking about consent as part of your work experience program. Let me share my screen. So, we're talking about informed consent. So, what does informed consent actually mean? I'm a cardiologist at Imperial College Healthcare NHS Trust and also at One Welbeck Heart Health. And I thank APPS UK for giving us the opportunity to tell you about it. So, consent is often seen as something that's very straightforward. You explain the procedure, the patient says yes or no, and you get them to sign on the dotted line, and there you go, you can carry on with your procedure. But as with most things, it's not quite as easy as that, because most things that we do have risks and benefits. So is informed consent needed if you say, can I take your pulse? Well, they hold their hand out, and therefore it's implicit that the patient has consented for that procedure, and nothing further needs to be written down. If you say, I'd like to do a blood test, now that's more invasive, that requires a needle. But again, if the patient holds the arm out and allows the tourniquet to be placed, then you would expect that they have consented for the procedure. Now, if there's a more intimate examination that's required, you're still going to do a verbal consent. They may have to adopt a particular position or remove some clothing, but you would expect there to be consent. Now, these days, with these intimate examinations, at least you should offer a chaperone to be available, not only as a witness to the procedure, but so that there could be no discussion about whether there was consent or not consent for the actual examination. Now, if the question is, can I remove your kidney, then you would expect more than just a quick chat and an assumption, and the patient lies down on the table, because this is a highly invasive procedure. There may be a very good reason for doing it, but you would expect more than just a verbal discussion. And so you would expect there to be something written down so that it can be referred back to, and a much longer consent process. So informed consent, what is it? Well, it's a process that will include all of the following. You're told, the patient is told about the risks and benefits of a particular treatment. You're told also about the risks and benefits of the other options, including doing nothing at all, because often doing nothing at all is not zero risk, but the patient has an assumption that doing nothing is safe, and it may not be. You've had the chance to ask questions about the procedure and the choices, and you've had them answered. So I've told you about the procedure and the options. Do you have any other questions? Now, that's an important thing to get out. You've had time to talk to your family. So often people will want to discuss with their children or their parents about exactly what needs to be happening. There may be a medical relative as well. You're able to use the information that has been given to you to actually make the decision. Do you have capacity to actually make the decision? And then you can share your decision with me as the doctor. So it is really not just a form and a signature, it's a process that takes some time to get right. If you don't get it right, then you may be assaulting the patient, and in the law, an assault is a perceived threat. So if imagine you're walking down the street, someone looks very aggressive and runs towards you, but doesn't actually hit you, that is still an assault in the law. If they do hit you, that is battery. And if you make contact with the patient and you haven't got their consent, then that is battery. Now, of course, when there's an emergency, the aorta has ruptured, you have to do surgery, then there's very little time for any consent process. And as long as there's a body of medical opinion that would be supportive of you, that is fine. And I do not think you need to wait for consent. It's the same when I'm dealing with a heart attack patient who's often drugged with morphine because of the pain. Then it is, I think, acceptable to ensure that you get on with the treatment. With those patients, because they're still conscious, I tend to get a signature, but I know that signature may not be fully valid in the law because they've already had medication. Now, if there's a complication during the operation and therefore the surgery has to be modified, well, then that's also fine. If you happen to cut the spleen when you're taking the stomach out and the patient is bleeding to death, you're not going to wake them up and say, "Can I remove your spleen?" It's also possible not to discuss with the patient if there are legal guardians and they have a power of attorney, as because the patient is not competent. And of course, during psychiatric illnesses, a consent for an admission for a psychiatric illness, you're not going to have that consent, and you're going to do it in the best interests of the patient. So the disclosure has to be in plain information. So in this country, in plain English, or if the patient doesn't speak English, in a language that they can read and understand. You also need to check that they can read it. We've had one very serious incident where a major complication occurred and the patient had signed a consent form, but it turned out the patient had just nodded through, had been unable to read, but was embarrassed about that and therefore just signed. That document then becomes rather null and void if everyone is aware in the family and in the general public that the patient could not read, but we haven't actually picked up on that fact. That is hard, but it did happen. Do they have the capacity? I've mentioned that a few times. Can they understand what it is that you're talking about? Do they have known dementia? Do they have unknown dementia? Do they have delirium, an acute condition which is making their capacity lower for understanding anything? So they need to be able to take it in. The consent has to be voluntary. You can't say sign here, otherwise your dad gets it, and that's ridiculous. So you have to be voluntary in the offering of that kidney, or the having an angioplasty, or having bypass surgery, or having your liver removed, whatever it is, it has to be voluntary. And the patients are allowed to make a bad decision. As long as they understand it's a bad decision, you're allowed to make a decision that is not agreeable to the doctor. So they've exercised their right, there's no external pressure and no undue influence. And that would include being forced by the family to donate a kidney, for example, to another relative. If the patient doesn't want to do it, you need to find that out, and the consent is not valid. So in history, interestingly, the oath that we all sign as doctors, the Hippocratic Oath, actually in there, the physician was advised to conceal most information from the patients because the patients don't know what they're talking about, and therefore we can provide better care. That seems rather outdated. In the 14th century, Henry de Mondeville also said, well, your hope is to cure every single patient, and you have to inspire the patient to believe that. And of course, you should try and meet the patient's requests as insofar as they don't interfere with treatment. If they interfere with treatment, then you keep it from them. That's not modern thinking either. In the 1800s, Percival was very clear that the physician could provide better treatment by lying or withholding information than he probably should do. And I think, again, that is old-fashioned. The modern idea that benevolent deception was not fair actually came around in the 1850s, 1849 to be exact, but actually did not catch on until very recently. So around the world, in the UK, the previous test when I was at medical school was the Bolam test. Would a reasonable doctor have done the same as you? And that made doctors very comfortable because you could always find another reasonable doctor to agree with what you were doing. Now, it is the Montgomery ruling, which I'll talk about, where as well as passing that test, a reasonable patient, so a lay person, would also make the decision that you made and find it reasonable. That's a harder test because patients vary in how they think about things. So a reasonable patient test is a much higher standard than a reasonable doctor test. In the USA, it is the reasonable patient, but on top of that, it is this particular patient. So for example, if I do something to the hand on a concert pianist, then the outcome of that with any problem may be much more significant than if the hand wasn't so important. And so it is that particular patient that you have to think about in the United States as well. Of course, we should do that here, but that's enshrined in law in the US. So here's case one, and you should think about what you would do. I will pause once I've posed the question. A doctor is performing routine surgery on a lady. Let's say it was an appendix being taken out or a hernia being repaired, something actually probably deeper, because inside, when they were looking, they saw obvious cancerous tissue on her womb. What should be done? The choices are: take the uterus out, it's obviously cancer. Or she's not consented for this, so you have to leave it in, wake her up, have a discussion about the do's and don'ts, and then take things further forward. So have a think. Well, the surgeon took the initiative and removed the patient's womb. There was no consent for that. It wasn't an expected complication of the procedure. It was an entirely unexpected situation. And the General Medical Council felt that he had acted negligently because he had not counseled the patient about it, that the woman could easily have made a different decision about what her treatment choices were, in particular because it was her womb, and that this was battery. So the patient has actually not only been assaulted by a perceived threat, but actually had physical injury. However, he wasn't struck off, and you can see that there are two sides to that story. Case number two. Mr. X explains the need for spinal surgery, and the patient agrees because Mr. X is a phenomenal surgeon with a great reputation. Mr. Y consents the patient 2 weeks before surgery, and as part of our NHS consent form, it is that the person operating cannot be guaranteed to be any one surgeon. The team is competent, any competent surgeon could do it. It's very rare that we'll be able to absolutely specify it'll be a particular person that does the surgery, unless it's very specialized surgery where only one person does it. On the day, Mr. X was not available and Mr. Y was available. He was trained to do the surgery and he performed the surgery. The consent process, is it okay or is it not okay? So the patient has a recognized complication. Patients often get very upset, even with recognized complications. They feel something went wrong, and the patient took it to court. The judge ruled that the complication could have occurred with any surgeon doing the operation. But interestingly, and this is why these cases are very difficult when the law becomes involved, and there is a real force behind saying that open judging of these sort of cases is very challenging, that he felt that Mr. X was more experienced, the patient expected Mr. X to be doing it, despite the fact he'd signed a consent form that said it could be any surgeon. Now, the outcome of that case, I'm not quite sure about, but actually illustrates the problems that can occur when a judge is making decisions in an area where he will not have the experience. He's making a decision in the eyes of the law, but that did not appear a common sense decision if in fact there was a finding against Dr. X or Dr. Y in that situation, at least in my opinion. So the third case is Montgomery that I mentioned before. Now, there was a baby being delivered, and unfortunately there was a complication during the delivery. The shoulder was large and the baby had difficulty getting out of the womb. There are two approaches you can take. You can either do an immediate cesarean section, an operation, or you can watch and wait and see if the baby will eventually come out. Unfortunately, the watch and wait approach led to some significant injury to the baby. So the court ruled that this was not negligent because both a reasonable body of doctors would have had a watch and wait approach, and it might be expected that some patients might also. So this was in the days of Bolam, before this case became case law. So with Bolam, where it's a group of doctors, there would not be negligence and not a breach of duty. But he did say there was a breach of the duty of care because the mother had not explained to her in the midst of her pregnancy and delivery and the pain that goes with that, that there's a risk with the shoulder, and of course the baby could get injured. And if these material risks had been explained, then a reasonable patient in that position would have attached significance to it And you might expect them to say, forget it, do the cesarean section. I don't want any risk to my baby. So this is where Montgomery has moved from a reasonable body of doctors that would have supported a watch and wait decision to a reasonable person test, where a reasonable person could easily have said, well, given the information, I will have the cesarean section, which is not a high-risk operation. So the Supreme Court also said that the mother had not been adequately consented for the less invasive watch and wait approach, and therefore there was a problem. So in summary, consent is not just a signature. A signature alone will not protect you in a court of law if the rest of the process has not been there. And one of those bits is the patient information sheet. When they're coming to hospital, patients can be very nervous and they may not remember much of what's said. But if it's been discussed with them weeks in advance, a letter has gone out to them listing all of the possible complications and their percentages, and they have read that information sheet, then that single tick that you put on the consent form, which says they have read that patient information sheet, or better still, if the consent form is a copy of the patient information sheet, so they've read it and signed it to say they've read it, and then you've signed it to say they've read it, is much better in making sure the consent process is solid. So thank you very much for your attention and for Apps UK for allowing you to see this.